Okay, so let's begin. I've already introduced myself as Dr. Sitwa Jazeel Farooqi. I am an assistant professor of neurology at the Civil Hospital, Karachi, affiliated with the Dow University of Health Sciences. The article that I'm going to be presenting today is the Epilepsy Treatment Gap and Stigma Reduction in Pakistan, a tested public awareness model that was published in 2020 in the journal Epilepsy and Behavior. We are fortunate to have one of the authors with us, Dr. Zareen Mughal, also present today. So let's begin. Just a brief overview of epilepsy. 50 to 60 million people worldwide are estimated to be affected by epilepsy. And out of these, 80% of people reside in developing countries. The prevalence of epilepsy is 2 to 3 times more in the lower and lower middle income countries than in the upper middle income and high income countries. More than 85% of patients with epilepsy in the lower socioeconomic countries receive no treatment or inadequate treatment. And they themselves have to carry more than 90% of the financial burden. That is, whatever the cost of the epilepsy, the treatment, the management, 90% the patient is bearing from their own pocket. The epilepsy treatment gap is basically the percentage of people with epilepsy who do not have access to treatment. And it is high in the lower and lower middle income countries, around 22 to 100%. However, in the upper middle income countries and in the high income countries, it's less than 10%. This is a graph from an article that was published in 2010. And it shows the treatment gap in the rural and the urban areas of various countries, divided according to their socio-economic status. So you can see, this is the arrow that shows Pakistan. And Pakistan has a significant epilepsy gap, both in the urban and the rural areas. In the rural areas, this is nearing 100%, and the urban areas, it's around 75%. This is another study that was published in 2013, which compared siblings with and without epilepsy. And the study concluded that siblings without epilepsy were more likely to be married, more likely to have a college education, more likely to be employed, and more likely to be better paid than their siblings without epilepsy. And this highlights the stigma that patients with epilepsy still face. This is another graph taken from the same article that shows the percentage of parents who would not let their children play with other children who had seizures or epilepsy. And as you can see, that there is a significant number of parents who would not let their children interact with epileptic children. And this is where the stigma stems from. This is where it all starts. If we talk about Pakistan, we have 2.2 million people who are affected by epilepsy in Pakistan. So that is 9.9 out of every 1,000. Most of these patients are less than 30 years of age. So there is a long life during which they have to have access to treatment and they have to continuously take medications. And the treatment gap, as we saw earlier, is very high, 98.1% in the rural areas and 72.5% in the urban areas. That indicates severe accessibility issues. Why does Pakistan have such a high treatment gap? Well, the foremost, the basic thing is poverty. More than 3/4 of the population is living below the poverty line. They have no money for their healthcare costs. They have limited access to free healthcare. There is no central insurance system or no central healthcare system that can accommodate all of these people. A lot of people, because of their cultural and spiritual beliefs, tend to gravitate towards alternate methods of diagnosis and treatment. Evil eye, evil spirits, and so on. The healthcare budget does not have a significant allocation for awareness or treatment of epilepsy or neurological disorders as a whole. Distances. People in the rural communities have to travel miles and miles to actually reach a hospital, any healthcare facility. And this creates problems both in the diagnosis as well as the access to treatment. Simple illiteracy and lack of availability of medications, and then distances. The patients can't reach healthcare facilities where they will be provided medications, and the cost. So all of these things influence the significantly high treatment gap in Pakistan. So keeping in mind all of these things, the prevalence of epilepsy, the treatment gap, the factors that affect this treatment gap, several studies were conducted in the 1990s that highlighted these problems. And a group of people got together, doctors and non-medical volunteers, to initiate the Comprehensive Epilepsy Control Program of Pakistan. And this program had two basic parts: the Epilepsy Support Pakistan, that was focused on raising public awareness about epilepsy and dispelling the myths surrounding epilepsy, and the creation of a National Epilepsy Center, which is to be a hub for the management, for the integration of care, for research and education to improve the access of low-cost healthcare for these patients. This program was divided into 4 distinct phases. The first phase was one of public awareness. It started with public sensitization through short bulleted messages displayed at various prominent areas of the country. And then there was the second phase that spread detailed information about epilepsy by organizing seminars, by visiting schools and colleges and speaking to the students and teachers there, and so on. So this is one of the earliest pictures. This is an awareness walk, and the participants are holding up banners that say epilepsy is a treatable disorder. A similar banner has been put up on a busy road, and this again says that Mirki, that is epilepsy, is a treatable medical disorder. These are children who are participating in an art competition, which the theme of epilepsy. And so social activities were also conducted to raise awareness about epilepsy. Auto rickshaws are a very popular mode of transport in Pakistan, and they are famous for funny poetry written on them. So these auto rickshaws were covered in banners about epilepsy, and they circulated throughout the city, spreading awareness about this disease. This is the gate of the main train station in Karachi, and this again has a banner that says epilepsy is a treatable disorder. After this first phase of short bulleted messages, then seminars were held that were educating both the doctors as well as the non-medical people about epilepsy. These are school children, and as you can see in the background, there is a red poster that details information about epilepsy in the local language of the area. Setups like these were placed in various prominent parts of the city. So this is a mall in the city, and they had this setup there where people were encouraged to come up, ask about epilepsy, and do away with any myths or any misconceptions about epilepsy there. These are medical students, and they were basically performing a play on epilepsy, thereby spreading awareness. Now, the second phase was one of a structured district model. The country is divided into provinces, and each province is divided into cities and districts and towns. So every district was taken, and in the first 6 days, volunteers from the district conducted public awareness activities in their own district. Now, these were activities like we previously detailed, along with announcements from the local mosques about epilepsy and it being a manageable disease. Flyers were distributed to educate people about epilepsy and the fact that it is a treatable disorder. On the 7th day, a free epilepsy camp was held in each of the districts. This camp was conducted by a consultant neurologist who voluntarily came from this camp from Karachi to the various districts. patients were diagnosed and treatment was initiated. And then epilepsy update workshops were carried out for the local primary care physicians so that they could then follow up and manage these patients of epilepsy while liaising with the consultant neurologist in Karachi. So this was the second phase of epilepsy awareness and treatment. The third phase was the establishment of the National Epilepsy Center in Karachi. And this National Epilepsy Center was established within the boundaries of the Jinnah Postgraduate Medical Center, which is one of the largest government-run tertiary care hospitals in the whole country. And Karachi is a port city. It is catering to patients within the city from the entire province of Sindh, as well as from another major province of Balochistan. So Karachi was a very ideal place for the establishment of this epilepsy center. And the final phase was the regular telecast of a short, about 1 minute, television documentary and continuation of these awareness activities through social media, Facebook, Twitter, as well as continuation of the public awareness activities. So then how did they assess the outcomes? Because it's difficult to assess outcomes of awareness campaigns. There are several scales, but the scales are difficult to apply to such a large population. So there were two methods of assessment, direct and indirect. In the direct method, a repeat population-based study was done in 2006 to calculate the treatment gap and compare it with the previous treatment gap. In the indirect method, which was a little unconventional, annual anti-epileptic drug sales data was collected through an impartial statistics company. And they saw how the sales of the anti-epileptic drugs varied during this period of awareness and so on. So let's see the outcomes. In the first phase, 45,000 illustrated epilepsy awareness posters were affixed in schools and public places. And these posters were in the local languages, along with pictures that explained epilepsy, its symptoms, and its management. Pakistan has a very widespread system of lady health visitors. These are ladies who are enrolled from their communities and given education regarding healthcare. And then they visit the houses to administer vaccinations, to administer polio drops particularly, and to address any small concerns that the families might have. And since they're residents of that particular area, they're very trusted and their opinion is highly valued. So these lady health visitors, 800 of them, were inducted in the Epilepsy Awareness and Training Program, and they were encouraged to identify patients with epilepsy and to counsel them to seek proper treatment. So this was basically, you can say, within the constraints of the Pakistani health system, these ladies were enrolled to help with this process. In 2003, Maulana Abdul Sattar Eidhi, who is Pakistan's most revered, most loved social worker, came out of the shadows and declared his diagnosis of epilepsy to the world and became one of CSCP's most motivational ambassadors. In phase 2, that is the phase of the district epilepsy camps, more than 12,000 patients of suspected epilepsy were evaluated, and around 8,000 patients were treated and followed up by the local physicians. 2,100 of these physicians were trained in the epilepsy update workshops. Now, I can give you an estimate. Pakistan is a country of around 22 million, if I have my millions and billions correct. For these many people, there are maybe around 500 trained certified neurologists. So everyone cannot possibly have access to a neurologist. So it's very important that these physicians were trained so that they could manage the patients with epilepsy. In phase 3, that is establishment of the National Epilepsy Center in Karachi, More than 10,000 documented patients with epilepsy from all over Pakistan were assessed and provided anti-epileptic drugs at a very token cost. More than 17,000 EEGs have been performed and digitally archived. And these are the statistics till 2020, till this paper was published. So these numbers of patients who have been managed and the EEGs that have been done must have significantly increased by now. And in the final phase, that of a television documentary, the marketing departments of 2 channels provided estimates, and it was estimated that 132 million people in Pakistan viewed the epilepsy awareness documentary through more than 2,000 telecasts. And these telecasts and this viewing of this documentary by people still going on. And this documentary is also now available on social media for viewing. The repeat study that evaluated the treatment gap in 2006 showed a 47.5% reduction in treatment. So in about these 10 to 18 years, 47.5 reduction in the treatment gap was done. Rural areas could not be very accurately assessed because of infrastructure issues. The anti-epileptic drug sales showed a 15.6% increase over the same period, while other factors such as the cost of the drug, the availability were kept static. So this is a graph that shows the anti-epileptic drug sales from 1998 to 2018, so 10 years. And you can see there is a gradual increase in the sales of anti-epileptic drugs. And about since 2012, there has been a steeper rise. So this shows that more patients were diagnosed with epilepsy. That means better physician and better healthcare worker awareness about epilepsy. And then more people were agreeing with their diagnosis of epilepsy and were agreeing to take treatment. So that is the dispelling of the social myths around epilepsy, that this is the evil eye or these are the evil spirits. They were accepting their diagnosis and taking treatment. An important thing here is that because pregabalin and gabapentin are used as for neuropathic pain extensively in Pakistan, so these 2 medications were excluded from this graph, from this statistical study. So how then did this public awareness campaign compare with other global efforts? So a global campaign against epilepsy was launched, and with the slogan of epilepsy out of the shadows. And initially demonstration projects were launched in countries like China, Brazil, Zimbabwe, Senegal to test and implement strategies for improving epilepsy care. And these included global outreach initiatives. So this was assessment of the treatment gap, as well as conducting awareness activities, capacity building programs for the healthcare workers and the community leaders, and then public awareness campaigns like the campaign in Pakistan to raise awareness regarding epilepsy and to dispel the myths around epilepsy. The results of this global campaign against epilepsy were increased awareness, so changes in public perception regarding this disorder. There was better access to treatment, and several countries integrated epilepsy services into their national health policies, like China. So this was a sustainable model. The Chinese model was very sustainable. And then in other areas, the outcomes were variable. So some studies had to be stopped because of lack of resources. Some studies were time locked. So then they couldn't get very good results because of the very small amount of time in which the study had to be conducted. And then some studies did not give proper results because of, again, in these lower and lower middle income countries, there is always a lack of resources. There's government red tape and so on. Another public awareness campaign was conducted by the Epilepsy Foundation in the United States of America that started from 2001 and continued till 2013. And various strategies were employed, including educational materials and community events, including endorsement of these events by several celebrities to raise awareness and reduce stigma surrounding epilepsy. And the results indicated that public knowledge increased about epilepsy. positive attitudes towards epilepsy increased, and there was greater advocacy for the rights of people with epilepsy. However, both these could not significantly show a numerical response because the epilepsy stigma scales, though present, are difficult to do and difficult to apply to a whole population. This was a study done in Bolivia, and it was published in the journal Epilepsy and Behavior, where they took participants from 3 communities in rural Bolivia. About 200 participants were initially recruited in the study. They were given a pre-study assessment, and then they were given public awareness materials, after which they were evaluated again by the stigma scale of epilepsy. And the study found that there was a significant reduction in the mean stigma scale of epilepsy score from 38.3 to 28.5. And on a qualitative level, patients with epilepsy experienced less depression, less memory difficulties, and less work and social issues. And they were also less scared of having a seizure in a public place. So this is a very good score, this stigma scale of epilepsy. But again, applying it to 200 people in a very localized population and applying it to a whole country or a whole city, then it's difficult. So what were the positives about this model of epilepsy? The program was implemented in sequential phases, and it adapted to the resources available in the country. Initially, when the volunteers went to schools and colleges and spoke with teachers and students, they found it to be time-consuming and did not have a greater impact. So then they changed their method. The funding was through local donations, and the commitment of volunteers ensured long-term continuity. Pakistan is a nation of philanthropists. Religiously, people are give alms and donations, and then people are very helpful, particularly in matters of healthcare. So these funding and the volunteers, they really helped to ensure that the study went on for a proper period of time. The model is simple. It does not need any equipment. It does not need extremely trained personnel, and it can be easily replicated by other developing countries who share similar epilepsy problems, as most of the lower and the lower middle income countries do. There are even patches in the higher income countries, specific populations, where there is a significant treatment gap. And the significant reduction in the treatment gap, 45%, and the reduction of stigma, evidenced by increase in the anti-epileptic drug sales, supports the effectiveness of this approach. The key challenges that were faced were that rural areas were not very effectiveness because of security concerns and other infrastructure issues. There is still significant cultural resistance to epilepsy awareness due to entrenched beliefs. And then there are insufficient training resources for healthcare providers who are in remote locations, far away from the cities. The limitations of this study were that there were a lack of formal tools to measure the stigma reduction. So we can estimate an impact, but again, how much the stigma decreased by how many percentage points, like in the Bolivian study, cannot be assessed in this study. Campaigns in the rural population could not be fully reassessed in 2006 for effectiveness. And then dependence on limited government funding restricts program expansion. So the volunteers and the donations can only help the program to expand to a particular degree. And after that, government support and integration into the healthcare policies is required to make this a sustainable goal. To conclude, stigma surrounding epilepsy still remains a critical barrier to treatment access and social inclusion, and addressing the treatment gap is urgently needed for comprehensive educational strategies to enhance the understanding of epilepsy among the community. Reducing stigma and promoting social inclusion are vital for improving the treatment-seeking behavior. When there is acceptance of the diagnosis, acceptance of the fact that this is a medical disorder that may be treated, then the treatment-seeking behavior can improve. Collaborative efforts are required by healthcare providers, policymakers, and civil society to create a very supportive environment for those affected by epilepsy. With this, I come to the end of this article. This is my beautiful country, and I invite you all to visit us. Now, I would first of all like to request Dr. Zareen Mughal, who is one of the authors of the study, to please comment on the presentation today and add anything if she wishes to add. And then we can go on to the questions.
Thank you, Dr. Sidra, for inviting me to this journal club. I am the youngest amongst everybody here present. So this is the first time that I am attending ILAES activity. Thank you so much. A very well presented journal. The article was presented in a very well manner. And I would like to say that, yes, I have been a very focal part of this entire you can say the epilepsy campaign that was started, and we have gone through a lot of highs. Lows were low, I mean very few, but the outcome has been very, very satisfactory, and we were lucky for to have a very, very visionary leader with us. As Dr. Sidra mentioned, that in a population for 22 million people, no, 22, I'm even wrong with my millions and billions. Anyways, so 220 million population, there are about 400 neurologists. But this is the status at this point of time. When we took off, there were neurologists that could be counted, the numbers could be counted on our two hands. There were very less, and and neurology was not an acknowledged super specialty. It always came under with psychiatry. So there were missions and to give it a status. Then epilepsy, which is one of the most treatable, most common disorder. So it was taken up by I would say the founder of neurology in Pakistan, who also initiated the postgraduate studies, in Pakistan, and Professor Hassan Aziz. He was visionary. He started on a personal level, then on an organizational level, and before anything could be done, he prepared a team of middle cadre neurologists who could deliver, because all this awareness activity is of no use or is of no help if you make the population aware, but if you cannot deliver. A person can be made aware, he would be charged up, he goes to a doctor, but if that doctor is not aware of the proper epilepsy management and the person does not get treated, then it is back to square one. He loses hope and he goes back to the alternate systems that are present in countries like Pakistan, India, and other low and low middle income countries. So it's not only awareness, but it's also creating human resource to provide adequate management. So amongst all these activities, the creation of middle cadre neurologists, the training of general physicians, and we believe that epilepsy should be treated. It should be treated by primary care physicians, and only difficult to treat ones should be referred to neurologists. And this would not only decrease the burden, but it would be easy accessibility to the people. They won't have to travel distances, spend money on their travel and stay and the cost, of course, they have to bear with it. So one has to develop, and what we did and what we uh, deliver, like our messages, that it has to be, I mean, this was our way of going about, but staying within our limits, the existing infrastructure, the indigenous ways that we can do. Every country, according to their socio religious and the status that they have, they can tap, they may having some wonderful out of the box views, and they can go ahead, start small, take baby steps, go ahead. And um, we would say that we should have, like in our region, in our countries, we should not have a very rigid, fixed plan, because we have to be open about it. Like the demonstration projects, it was a wonderful project, but what happened was it was time limited, it was financed, it was in a limited area. So when the finances were withdrawn, when the time period went off, the people who did not have that support, the activity did not go ahead beyond the demonstration project for that period. China is you can't call it a low middle income. It is one of the top, like high income countries, and their government system is very, very powerful. So it was easy for them to integrate this plan into their national health policies, which I don't know, Dr. Sidra would agree with us that it is very difficult, at least in our country. And we prefer to stay away from the governmental bureaucracy, because when they are involved, it is, like you take 10 steps back or your work slows down. So you have to be, it has to be a personal investment. It has to be, do not rely on governmental aids, or do not rely on um, foreign aids, which come as a time locked policy. We, in our whole campaign, we never, ever encouraged free distribution of anti-seizure medications, because the person needs to know that it can be a lifelong problem. They may medicines lifelong. There is no agency that can provide you lifelong medicines in countries like Pakistan and the other low and low middle income countries. So they have to make their resources, they have to find out. But yes, we can help them out. We can help them with their stigmas, their socioeconomic problems, good holistic management. And if you provide that, which we have been providing since 2007, National Epilepsy Center was built in 2007, and we have seen wonderful outcomes, wonderful outcomes. And to say that the people cannot afford, yes, we do support them. We take a token cost, but people who are located in far off countries, we provide them telemedicine. But when they see the difference, they go ahead, they purchase the medicine, and they get themselves treated. Now, again, where medicines are concerned, the choice of anti-seizure medications is very, very important. In the urban centers, we get, at least I will talk about my country, we get the latest, not all, but we can get the newest of anti-seizure medications. But it would be very, very unfair to prescribe those medications to the people who are poor, who live below the poverty line, and who stay in distances where these, as my professor would say, these fancy drugs are inaccessible. Fancy in the sense that the first line medications like carbamazepine and valproates, they are time tested drugs. And the newer drugs, they are still to stand by the challenges of time. We are already seeing problems like with levetiracetam, which was said to be the most safest. It has been associated and seen to have lots and lots of psychiatric issues. Topiramate is another which impacts the cognition. So we, within our limits, within the type of drugs that we can use, we can make the most of it. And counseling is very, very important, very important. And giving them social support, giving them empathetic a year to, like listen to what they have to say, and then a little bit of strictness about their compliance and everything, and we are well to go. So when you address the stigma, then the management becomes very, very easy.
Thank you, Dr. Zareen. Very, very important points, and I do agree with all of them. Definitely, I think the main part of your article was that without any governmental help or support, and a group of people's medical and non-medical volunteers achieved such an incredible result. And all of this is still going on. And that is, I think, what sets this apart from all the other studies that I discussed, that they all had some sort of government support or support from the large epilepsy associations. So I think this is something very positive that other people can learn from, that you don't necessarily need all of that to make a change. So I think that's a very important message in the article. We have a few questions. Dr. Abdul Hamid Khan has asked that in the data slides shown earlier about stigma related to sibling with issues in marriages and playing with each other, does that include data about Pakistan? So no, Dr. Abdul Hamid. The first study that was about siblings was conducted in Malaysia. And the second one about children not being allowed to play with other children, this was conducted in, again, the East Asian countries, which are, again, as Dr. Zareen pointed out earlier about China, are not lower or middle income countries. They are high middle income or high income countries. And even there is a significant stigma. His second question is regarding public awareness campaign in developed world, as shown in the later slides. Are the stigma in those countries same as in Pakistan? So no, not necessarily as much as we have here. Again, the stigma here has not been quantitatively in terms of a number quantified, neither has it been done over there. But they are high-income countries. They have a treatment gap of around 10%, which shows people are getting access and are taking treatment for epilepsy. But even in those high-income countries, there are specific groups of people, usually on a cultural basis, that do have decreased acceptance of epilepsy as a medical diagnosis. And then there's the stigma and the treatment gap present in those particular groups as well. And
may I add something?
yes,
Sorry, Dr. Sidra. Dr. Abdul Hamid Khan also mentions about the AMILs in the country, and they leave the children with those with the AMILs and everything. So now when we are talking about stigma, and we did not, like as you mentioned, we were unable. Actually, like stigma is a thing that is very, very difficult to access, and you cannot access with, and you cannot find the results because of there are two types of stigmas. One is enacted stigma and the other is perceived stigma. And the perceived stigma is the stigma of which nobody talks about. Nobody and nobody. And it is very difficult to put it onto a scale. And no matter what you say, it's not there. So talking about the AMILs, like we, amongst the other things, we have approached the traditional religious schools called madrasas, and we were surprised that one big madrasa in Karachi, when approached, they said that they had at least about 40 children with symptoms that were similar to epilepsy. parents, the children are not taken into the normal schools. The parents, they think that it is the will of the God. If they start going into the religious studies or anything, they put them into madrasas. But they have even become very aware of it. And it is so surprising. There are so many religious leaders, the imams, the people who lead the mosques. Um, People tend to go towards them, and I know of at least two or three of them who have told the people that listen, this is not a spiritual problem or anything to do with spiritual evil eye or anything. It's a medical problem. Please go here and have yourself treated. So the awareness, it all depends upon how sincerely, and your awareness campaign has to be sustained. It's not that we started our formal sustained campaign in 2001 and we sit back now in 2024 saying that, oh, we've done our job, we don't need to, because the memory of the people is very short lived, and it just comes into their minds when they come across such a person who is near, dear, or known to them. Until then, the awareness thing just fizzles off, or it stays on a back burner somewhere in the hindsight of their brain. But awareness activities must be sustained. You can take a back seat, but some awareness activities in the background should keep on being done, so that the people keep this whole thing stays alive in their minds. So sustained awareness is the key.
Yes, Dr. Zareen, I do agree. And I remember working in a public sector hospital, we had a slip where a patient, a young boy, had seizures and he was taken to the mosque. And the imam in the mosque, he wrote down some verses for the parents to recite, but at the bottom he wrote down, take the child to a neurologist. So it's definitely, I agree with you completely that if we impart this awareness in a way that actually people understand and continue to remind them, then people are very cooperative. So thank you so much, Dr. Zareen, for joining us and your input. And there are no further questions. I'd like to thank all the participants for taking the time out today on your holiday and joining us. And just to conclude, we attended so many excellent journal clubs, and we talk about advancements in the management of epilepsy. But while we're advancing our management, we also need to make sure that we don't leave anybody behind, that every person with epilepsy is diagnosed and is treated. And that was the basic the basic reason of presenting this wonderful article here today. Thank you all very much for joining. And
Before I take,
yes, Dr. Zareen.
So this is the era of IGAP, right? And
Yes.
What is IGAP? This is exactly what is being addressed. Epilepsy has been a forerunner. It started with the global campaign, went on to the global outreach, and it is a continuation, the IGAP in epilepsy. And that's why it's called IGAP in epilepsy and other neurological disorders. So epilepsy has been a forerunner, and we hope to continue with that, not in the next decade only, in decades to come. We have to. Thank you.
Okay, thank you everyone for joining us today. And I hope you all have a very good day.